everyone. Welcome to our Evolve Parent webinar. Although this admittedly is not just for parents, this is also for loved ones generally, other caregivers, family members, really anyone that has someone close to them that is experiencing borderline personality disorder or suspected symptoms of. And looking forward as people filter in to being able to share a lot with you all and help with whatever journey you're on in the orbit of this disorder. Okay. In the interest of time, given that we have an hour together, I want to be able to get started and really give an opportunity to dive into the material so we have time to cover everything and then even perhaps answer questions in the chat at the end of the presentation. So with that, I want to formally introduce myself. My name is Allison Orsina. I'm a licensed marriage and family therapist in California and am the Chief Clinical Officer at Evolve Adolescent Behavioral Health. So for those of you who aren't familiar with Evolve, we are a provider in California of treatment for teens aged 12 to 17. It's all we work with and involve is teens, and we have residential and PHP IOP levels of care. And so my passion is working with teens in crisis and their families. And so I'm happy to share a lot of my knowledge and experience, having worked with this population for many years, and at Evolve in particular since 2016. I started out at Evolve as the director of our first comprehensive DBT program down in Los Angeles. And I am an intensively trained DBT therapist. So that's my clinical passion. And in specializing in that form of treatment, I've been able to bring that treatment modality to Evolve more strongly, and have, in my current role as Chief Clinical Officer, been able to influence clinical policy, development, training across all of Evolve. And as I've worked in this population for many years, I've really come to have such a passion too for working with teens that are in crisis, either with substance use, mental health disorders, and in particular for teens who are experiencing symptoms of borderline personality disorder. So if you're joining me today, it's likely because you have a loved one that you may suspect has borderline personality disorder or has had a confirmed diagnosis of borderline personality disorder. Since that phrase is a mouthful, you'll often hear me refer to this disorder as BPD throughout the presentation, just as a shortened way to talk about that experience. So today in our webinar, we're going to talk a lot about what BPD looks like in teens. And again, since I'm gearing this towards members of the community and not necessarily mental health professionals, I'm going to try to gear how I talk about this for the layperson, right? For you to understand if you have a loved one with this experience. I'm going to talk about the factors that contribute to the development of BPD as we understand it in current literature. I want to talk about separating myths from realities regarding BPD. And this is a really important aspect of discussing BPD as well, is there's a lot of work that we need to do as a community, both within the larger community and among mental health providers, of destigmatizing BPD. And so separating myths from realities is a big part of that. I'll also want to talk about key steps to take if you suspect your teen may have BPD or BPD traits. So for those of you who don't know, May is Borderline Personality Disorder Awareness Month, which is why it was important for us to host this webinar in the month of May. In order to kind of bring that attention to the disorder, to destigmatize the disorder, and help increase understanding and access to care for people with the disorder. This is a really important part of why I wanted to do this presentation. I think the disorder is highly misunderstood and often maligned. And it's really important to me, having worked with these individuals for many years, that their true experiences are really understood deeply and compassionately, so that we can all work together as a broader community and a mental health community to give them effective support. So, what is borderline personality disorder? So, there are many different personality disorders that we've named in our Diagnostic and Statistical Manual, our DSM, our manual for diagnosing mental health and substance use disorders. And each of those personality disorders has a different cluster of symptomology that comes with it. The hallmarks of BPD are significant challenges with emotion regulation, interpersonal relationships, and impulsivity. Those are the hallmarks for BPD. As with any other personality disorder, the behaviors that we see must also occur outside of what's normal for the person's age and culture. So if we're looking at a bell curve, right, of what may be considered normative, we're looking at things that fall on the outskirts of that. So not in the middle of the bell, but on the very tail ends of it, on either side. And we're looking at behaviors that are pervasive, meaning that they didn't just happen for a couple of months and then recede, meaning they were persistent over long periods of time and occur in multiple contexts, meaning it's not just something that happens at home with mom and dad. It's also something that happens at school, with friends, maybe at their part-time job, etc. And of course, for any of our mental health disorders in our DSM, it must also lead to impairment in functioning. This is an important aspect of how we define mental health disorders. So when we're looking more in detail about what all of this means, I really want to focus on the concept of emotion regulation. The role that emotion regulation deficits plays in BPD cannot be understated. And this is really something, again, that really makes it a unique experience compared to other mental health disorders you may be familiar with. So we all have varying emotion regulation abilities, and we typically start to learn how to regulate emotions all the way back in our infancy. So even when we're back to even being newborns, how our parents respond to our needs when we cry or we wet ourselves or we try other ways of communicating, how responsive they are and how soothing they are to our cries is the initial moments when emotion regulation starts to develop. When someone notices our upset and responds to it in a way that is comforting, and the act of being soothed by someone else in that way teaches us that our emotions may make sense in that moment, and that there's things we can do either internally or with the help of someone else to manage emotions. That process continues throughout childhood, right? When our children are upset and come to us and cry and express they're sad about something or fearful about something, how we respond as caregivers or how others in the environment respond as caregivers helps to shape their ability to manage the feelings they're experiencing. So at its basic core, emotion regulation is the ability to name your emotions. So notice that an emotion is there and what to call that emotion. It involves understanding emotions, meaning why are they there in the first place, how they might be useful to us, how they're often an adaptive response to stimuli in the environment. For example, this could be a very protective function if we're walking in a dark alleyway by ourselves at night and we have the hairs stand up on the back of our neck because our minds and our bodies are sensing something that causes fear. This can trigger us to fight or flight, as it were. It's important information for us to help know how to safely navigate the world. And In terms of emotion regulation, we're also involving steps to prevent the frequency of intense emotions and what to do when intense emotions show up. So you can see that this process starts very basic, in that some people with big emotion regulation deficits uh, struggle to do the most basic aspect of this, which is to notice and name an emotion that's present, let alone to know what to do when the emotion is extremely intense and it seems to be taking over their actions. And so people with BPD immensely struggle with this. And in many cases, we might notice that these individuals have had something called high emotion sensitivity. So this is something we talk a lot about in DBT, dialectical behavior therapy, because again, we're working a lot with folks with BPD, and we notice a lot that the people we're serving have had this high emotion sensitivity, again, way back even sometimes to infancy, or for our teen clients, their parents will be telling us, I've noticed this their whole life, that maybe they experienced emotions more intensely, or that things in the environment seem to trigger them a lot more than for me or for other people I know. And then it takes them a long time to return back to their baseline. And so this is an intense full system response when you're experiencing intense emotions, meaning that their body's activated, their mind is activated, all of their senses are activated, and that this emotion response can take over a lot of their lives. And we have some preliminary research that suggests that the high emotion sensitivity may be a biogenetic temperament, meaning that this may be something that some people are born with, and it really depends on their interaction with their environment, how effective of a trait this or a temperament this is for them or not. It does not have to be a negative thing. Sometimes it could have benefits. And I know a fantastic clinician and researcher in the field named Francesca Perepechikova does a lot of work on DBT with children, and reframes these individuals as being super sensors. If you follow Dr. Becky on Instagram, you may also hear her talk about the deeply feeling kid. This is kind of all the same idea here. Someone that feels emotions very deeply and intensely, and maybe much more activated by the environment than others. And so what I want us to do when thinking about what it might be like to navigate the world with this temperament, I think as mental health providers working with people with BPD, and as loved ones who have someone with BPD, it's really important to put yourself in their shoes and understand what this might feel like. Marsha Linehan, the creator of DBT, has talked about this experience being almost like that of an emotional burn victim, where if you imagine navigating the world with severe burns all over your body, and the slightest movement where you brush your arm against a wall or lightly bump into a table would create excruciating pain. That's what it can be like for someone who has high emotion sensitivity and difficulty regulating emotions. The world is an array of emotional minefields that they have to navigate daily, and they're constantly in and out of intense emotional pain. So when we think about that and how that might impact someone's daily existence, we can really start to imagine how challenging it would be to navigate even the basic of everyday circumstances, like making a new friend or meeting up with a friend or navigating school stressors, or hearing your parents say, no, you can't have your cell phone tonight. Like, for our teens that are experiencing this, these are all emotional landmines that are really hard to manage. And so when we're thinking about the perfect storm that creates BPD in adolescence and beyond, what we're looking at is likely the point at which biology meets environment. So if we have an individual who has a high emotion sensitivity, maybe that biological temperament that they have from birth, and we combine that with an environment that's not equipped to support them through that experience. Sometimes the environment may be a highly abusive one. Around 70% of people with BPD do have a history of physical and or sexual abuse, though that doesn't have to be an essential ingredient for creating BPD. Sometimes what we see is that we have very well-meaning and well-intentioned caregivers who simply don't have the tools that are needed to respond to the intense emotions of their child. This is really hard, to have a deeply feeling kid, to feel the chaos of their emotions, and to really not know what to do about any of that. And so a lot of times parents really need a lot more support in managing kids that are highly sensitive, have intense emotions, and have a hard time regulating, to help them to be able to build these skills. And when we have someone who's highly emotionally sensitive, and we have an invalidating environment, what we mean by that is that it's an environment that maybe questions their emotional experience, puts down their emotional experience, dismisses their emotional experience. It can sound sometimes something like, why are you crying again? You're always crying about something. There's no need to cry about this. You just need to get over it. And now, this could be, something on a more regular occurrence from a parent. It could also be a parent who's out there with end and doesn't know what to do and really just needs help to know how to support their child. What this leads to, especially for someone with high emotion sensitivity, is it leads to distrust of their emotion experiencing. They're thinking, I have all these big real feelings, and every time I express them, I get told that's wrong, or I get told I shouldn't feel that way, or I get punished in some way, I get a privilege taken away. They no longer know how to express emotions effectively, especially if effective expression is punished in some way. They really don't learn any tools for managing their emotions. Instead, the responses, like maybe acting out, tantruming, being aggressive, threatening to hurt yourself, those responses are punished, but they're not done on alongside teaching of effective tools to manage emotions more safely and effectively. So again, these experiences over time can lead to that chronic and intense emotion dysregulation that we see in borderline personality disorder. So when we're looking at the full criteria for BPD, of course, on the previous slide, we talked about like the impairments that need to be present, that this needs to be pervasive and occur across multiple settings. We're also looking at whether at least 5 of these criteria have been met, again, pervasively and across multiple settings. And so this is the general criteria, and I'll talk a little bit more in a bit about how we're assessing this out for teens specifically. So here we have frantic efforts to avoid real or perceived rejection or abandonment. So again, this high sensitivity is often really very much triggered by things that happen interpersonally. So threats of rejection or abandonment are scanned for constantly, and the responses to what we might see as a minor slight can be very intense and very painful for someone with BPD. There's often a pattern of unstable and intense interpersonal relationships. And these relationships are often characterized by bouncing back in between either idealizing someone and totally devaluing them. So for a teen, this could show up like creating an intense new friendship very quickly. You've just met them and now they're the greatest person you've ever met. You want to spend all your time with them. And then maybe a week later, they picked up on something that feels rejecting. And now that person is completely dead to them. Can't believe I ever wanted to be friends with them. I want nothing to do with them. So again, there's big extremes that they're vacillating back and forth between with regards to a lot of things in life, but especially within interpersonal relationships. We're seeing persistently unstable sense of self, and now this is beyond the identity exploration that's common for teenagers. This is more along the lines of they have no consistent interests. They don't know what their values are. They don't have any goals. They really are changing a lot about themselves based on who they're around and what they're interested in at that time. We're looking at impulsivity in areas that are potentially self-damaging, a recurrent suicidal behavior, gestures or threats, and or self-harm behavior. We're looking at moods, again, that change frequently throughout the day. So this is that affect instability or mood dysregulation that we've been talking about. And what this looks like in BPD is much different than in bipolar disorder. And we'll talk about that a little bit more later in the presentation. Sometimes this involves chronic feelings of emptiness, feelings of numbness, and sometimes for some people with BPD, this can really, align with, again, that lack of sense of self, feeling kind of rudderless. It can also accompany like the numbness you might feel when you're flooded with intense emotions and your body does no longer have the capacity to process that. Instead, you kind of just go flat. It can also include intense anger, difficulty controlling anger. So this could be temper outbursts, anger outbursts. It could involve physical aggression or not, maybe sometimes just verbal aggression. And then for some people, they might experience stress-related paranoia or dissociation. So this tends to occur largely in the context of interpersonal stressors. For example, having the persistent paranoia or fear that others are talking about you or dislike you or spreading rumors about you. The paranoia here doesn't really tend to be more bizarre paranoia you would see with something like schizophrenia. So it's not going to be something like aliens are watching me and are planning to abduct me tonight. It's really more related to interpersonal fears. When we're looking at how this presents in teens, it's really important to focus on what we call our internalizing factors. So you can tell from our criteria here, and I might go back a slide, there are some aspects of the disorder that are really acting out, meaning externalizing factors, things that people can see, big behaviors. So this could include things like impulsive behaviors, driving recklessly, using substances recklessly, having risky, unprotected sex. It could look like the suicidal behaviors or self-harm, anger outbursts. All of these are more of the acting out pieces of the disorder that in teens, we want to make sure that we're not providing the diagnosis based on those criteria being met alone. We're really more able to accurately identify the disorder in teens when we're observing the presence of the more internal parts of the disorder. And these are the pieces of the disorder that are really characteristic of BPD alone and not so much other disorders we might see in teens. So example, that the intense fear of rejection or abandonment, this is really one of the hallmarks of BPD. And if this is present and really pervasive, this could be an indicator of the disorder. So excessively seeking assurance from friends. Have I upset you? Are you mad at me? Is there anything I can do? Maybe sending them tons of text messages or calling them or showing up at their house to make sure they're not mad, meaning making sure you're not going to leave me or reject me. So a lot of clinging can happen here. Some folks with BPD may be terrified of being physically alone because it means they might be abandoned or rejected. And again, there's a lot of sensitivity here to external cues in interpersonal settings that they're always kind of scanning for to be hypervigilant about signs of rejection or abandonment. Unstable sense of self is a feature unique to BPD and is one of our more internalizing factors. So this could be someone that lacks core values, who, based on who they're hanging out with, they will change everything about themselves, how they talk, what they're interested in, their music tastes, their fashion tastes, their religious beliefs, all of these things, political beliefs, that can all sway with the wind based on who they're around and really who they're wanting connection with. It can also look like the intense interpersonal storm we've talked about. So the vacillating between idealizing and devaluing, intense breakups, chaos in relationships. This is also one of the hallmarks of BPD. So we want to be careful on the clinician side that we're not just flagging. First of all, we're not flagging typical teen behavior, and we're not giving a diagnosis based on acting out alone. So the reality is that some teens may show one or more traits of BPD, but never have the full-blown disorder. Or they may show behaviors that are skip and hop away from meeting criteria, but maybe are a bit closer to more typical teen behavior. For example, teens are going to have interpersonal difficulties, navigating peer pressure, bullying, cliques at school. All of this is challenging for teens, and it's not uncommon for teens to struggle as they navigate this. What's more, on the less common or typical end of things is constant blowups and breakups, and the switching between idealizing and devaluing others in those relationships. Typical, maybe sometimes feeling down and moody. There's a reason we talk about teen angst. This is a thing for kids in this developmental phase to be experiencing big hormone shifts, different things coming online psychologically and developmentally for them. And it's not uncommon for them to be touchy or irritable. And on the other end of this, frequent and significant mood swings. So this could look like highly elated in the morning and then so devastated and down because of perceived rejection from a friend, and then highly anxious about a test, and then highly elated again later in the day. So this is a roller coaster. This is up and down throughout the day in intense fashion. Typical teen behavior can, of course, be about self-discovery. This is a developmentally normative part of this phase of life. They're going to try new things, explore, push limits when they can. And the difference is there's no, for someone with BPD, there's no consistent interest or values. There's no core to them that persists as they try out new things, figure out where they want to be in life, etc. For typical teens, they're, of course, getting moody again. They maybe get angry and yell at parents and try to push limits and push back on rules. That's all pretty normative for a teen. And the difference here is the frequent and severe anger outbursts that treads toward screaming matches with swearing and punching walls and throwing things, or this happening at this level multiple times a week. That's more on the outside of that bell curve. And lastly, of course, again, feeling touchy or sensitive, that may be typical for teens to an extent. And for someone with BPD, we're seeing that extreme emotion sensitivity that's really been present since earlier in childhood and results in some significant difficulty in regulating emotions. So I want to talk a little bit about misconceptions, because I think that there's no shortage of this. And unfortunately, a lot of that comes from inside our mental health community, so our community of mental health professionals and psychiatrists, therapists, etc. And of course, things like media depictions certainly don't help. Without naming it as BPD, a lot of media depicts the crazed female who's jealous and will do anything they can to win back their man, even if it ruins his life. So we see stories like this with Fatal Attraction, for example. We see it named in movies like Girl Interrupted, which is adapted from a book about a character played by Winona Ryder who reportedly has BPD. And what the problem with these media depictions is they're not really exploring any of the internal misery that's experienced by these individuals. They're depicted as crazed and dangerous and like a blight on society and relationships, which is just such an unfair representation of the suffering experienced by these people. And it's really not all accurate. BPD can present in so many different ways that it's definitely not a one size fits all kind of scenario. A lot of times, and I know mental health professionals are especially guilty of this as well, people are referring to BPD, people trying to survive in their disorder as manipulative, okay? The problem with this is that when we label behaviors as manipulative, one, we are probably creating some intense emotions in ourselves about that person, which makes it harder for us to feel empathy for them, and it's harder for us to help them. And secondly, it also prevents us from truly observing the behavior and understanding it and helping them to change it. And so we really do a disservice to our loved ones with BPD and to our patients and clients that may have BPD if we're referring to their behaviors using this pejorative term. A lot of people assume, well, this client lies like it's breathing. That must mean they have BPD. I mean, maybe, and this really, as you've seen, not a diagnostic criteria of the disorder, maybe an associated factor, but I think it's often an unfair association. People, clinicians alike, will often refer to people with BPD as unpleasant, unlikable. They'll suck the life out of you. I've literally heard mental health professionals talk about people with BPD this way, and it's so unfortunate. And that's another reason why it's so important to me to have these discussions with other professionals in the community, so we can undo a lot of this to be able to better serve these individuals. Many people in the mental health community find people with BPD too difficult to work with, and they sometimes refuse to work with them because of the stigma that they have about the disorder. It's a myth that BPD is untreatable. It is absolutely treatable, and with the right treatment can have a lot of success with remission of symptoms. It's assumed that people with BPD are sociopathic or lacking in empathy. Nothing can be further from the truth. Some people with BPD are highly empathic, and this goes along with being highly sensitive individuals. They may not always be able to anticipate how their behavior impacts others, and when they do, it's deeply wounding to them, and can unfortunately lead to even more target behaviors. And lastly, of course, there's a belief that this can't be present in teens. Also not true, and something I want to help dispel. So again, the reality of BPD is that people, in the most non-judgmental terms, people with BPD have learned how to get their needs met in the best way that they could in that moment. And those ways may have caused them other problems. And so our job as loved ones or providers is to help, validate the valid of their experience and teach them new ways of solving their problems that don't alienate relationships or damage their bodies or result in them being in the hospital, etc., or even for some result in ending their lives. One of the most painful things that I've observed about BPD is how much a lot of these folks deeply care about relationships, how it's one of the most important things to them in life. Even when they don't know who they are, they know that they want friends, they know that they want connection. And the ways they know of coping with their symptoms ends up inevitably pushing people away from them. And so this is an endless cycle of rejection, abandonment, and pain. And being able to help them get out of that hell is a big part of what treatment for BPD looks like. And as I mentioned, BPD can present itself in many different ways. We may have some people with BPD who have no unstable sense of self. They know exactly who they are and are steadfast in their interests, and others where this is really uncertain and quite dysregulating. It just depends on the person. So as I mentioned, BPD is very treatable. And, it's hard for people in the mental health community to understand this if they've not been trained to work with people with BPD. It's also hard for insurance companies to understand and accept this. It's a persistent barrier in working with private payers that they will not fund a lot of higher levels of care for people with BPD because they believe it's a chronic disorder that won't get better, which is hugely unfair and not in line at all with the reality. So I wanted to give you one snippet about this. So this is one story by Gunderson et al. And they really looked at longitudinal study of individuals. So this is not maybe teen years, later adolescents, age 18 to 49. They looked at over time the rates of remission of symptoms, and they saw that over 10 years, 85% of these people experienced remission of symptoms, and that there are high rates of remission and low rates of relapse in the 10 years after onset of the disorder, particularly with those externalizing criteria like suicidal behaviors, self-harm, impulsivity. So this may give us an idea that from time of onset, there's a 10-year period where things might peak, where all of these acting out and dangerous behaviors might be most present. And our job as loved ones and providers is to get them safely through the roughest patch of their illness, keep them alive, out of jail, out of hospital, and being able to get to clarity on the other side and build a life that they want. The impairment in social functioning with BPD tends to be something that is more persistent, still can be responsive to treatment. And we're seeing that at least in this study, that the externalizing factors of the disorders were most responsive to remission. As we see with adults, teens with BPD tend to have more co-occurring mood, substance use, eating disorders than teens without BPD. So the percentage of teens presenting to higher levels of care, like residential, inpatient, PHP, IOP, the percentage of those kids with BPD traits or full BPD is pretty high compared to the average population. So, can BPD be diagnosed in teens? Absolutely, yes. It's a long-standing misconception that it can't be diagnosed prior to age 18. In the past, that's been the common understanding in the mental health community, that personality was not fully formed in the teenage years, and that there's no way we could possibly reliably diagnose this prior to 18, as if when you turn 18, you magically have a solidly formed personality at that very moment and can now have this pathology or not. It's really not how things work, as we've found. And there's been research going on for decades about this very phenomenon. A lot of clinicians still believe the DSM does not permit this, when that's actually false. In the section of the DSM that discusses general personality disorders, there's a section that states very clearly that the diagnosis can be given, but needs to be done judiciously. And we really need to take care to ensure that if the person's under 18, that we've seen the criteria fully be met for the disorder for at least a year before providing the diagnosis. A lot of people don't realize that, even though it's literally under our noses in the book. And many lack the training on effective assessment for BPD and lack the awareness of the current research showing the validity in doing so. So again, another important reason why I'm doing this presentation, why I've done similar presentations, but for other members of the mental health community in terms of providers, is that I want us all to be able to shift our thinking on this. Some snippets of research findings on the topic. So one study from 2002, so you can see these studies have been going on for a long time about this. This is not something brand new. We are seeing that in hospitalized patients, BPD and its symptoms appear to be as frequent for adolescents as for adults. They thought, okay, this is interesting, more research is clearly needed. And so a later study in 2013 showed that adolescents in inpatient and PHP settings, that 30% of the sample met criteria for BPD. Okay, and that the 9 BPD criteria demonstrated good internal consistency equivalent to rates reported in adult samples. This, the reliability and validity remained satisfactory even when the analyses were limited to younger adolescents, even between the ages of 12 and 14. So to translate the statistical terms for you, they were finding that the traits were reliably and persistently present for these teens in a similar way that they would be an adult who you were assessing for the disorder. So there was really no indication in this study that the common thinking on this was true, right? I think the common thinking is that this won't be persistent because they're still developing and things are constantly changing. And that's really not what was reflected in this research. So why would we want to do this? Why would we want to diagnose in teens? I know some families feel hesitant about this because, again, there is so much stigma. They don't want a label stamped on their child that will be there for life, and because that label in their mind is extremely bad. And I guess what I would pose is that it's neither bad or good, it just is. And that for many families and clients, the naming of what's happening to their child or happening to you, if you're the person with the disorder, is extremely validating and produces a lot of clarity and understanding of what's happening to me, that other people are experiencing what's happened for me, and that there's a way out of this hell that I'm experiencing right now. And that I can live a life that I want to live, that I experience is worth living if I'm directed towards the proper treatment. So there's a lot of evidence that's showing that early diagnosis leads to early intervention, which leads to improved outcomes. So a snippet from this one study. This shows actually that for some people with BPD, the symptoms may peak at around age 14 to 17, which makes the case that early intervention is key to prevent more severe outcomes. If we're naming this and directing them to appropriate treatment early on, then we can avoid a lot of misery in their 20s and 30s if we were kicking the can down the road and getting them what they need. And it's really key too for us to be able to direct them towards evidence-based treatment for the disorder. So if you or someone, I guess more for if someone you love, you're thinking, okay, this sounds a lot like my child or my sibling or whoever is in your life. What can you do about this? If they're a minor and you're having a hard time being taken seriously about what your child is experiencing, or you've heard some providers say, I think it's BPD, but we're not allowed to diagnose. Be an advocate. Reference the literature, and I would point you. I'll point you in later slides for some resources where you can do a deeper dive on your own if you'd like around the research pool for supporting BPD diagnosis in teens. You can ask that they be screened with appropriate tools. For example, the Borderline Personality Features Scale for Children is a tool that's been validated for adolescents specifically. This is developed by Carla Sharp out of Texas. She does a lot of great work there and is one of the leaders in the research around this topic and the importance of destigmatizing BPD through early detection. I also recommend that you consult a DBT clinician. And the reason I say this is because as DBT therapists, we're trained to see BPD and to treat BPD effectively. And so there's less stigma in our community of clinicians around diagnosing this earlier when it's truly present. So you may see less barriers to that there. And in your advocacy efforts, you can focus on the need to link with appropriate treatment and support. So at the end of the day, if you have a strong feeling that your loved one may have BPD and no one will take you seriously, at least see if they can provide you with appropriate treatment and support. So if we're not naming what we see, at least we can support what we see and help your loved one be able to get through the most challenging parts of the disorder safely. So I also want to touch briefly on common misdiagnosis. This is not uncommon, and I bring it up because a lot of times we see this at Evolve. We do diagnose BPD in teens at Evolve in alignment with what research supports. And we see a lot of kids coming in with some of these other diagnoses that are provided erroneously. Bipolar disorder is a popular one, especially for providers who believe, yeah, there's definitely something happening with mood, and I believe I'm not allowed to diagnose BPD, so I'll give you bipolar disorder. The symptoms do not align with bipolar disorder. So with bipolar disorder, you're seeing clear mood episodes that last days to weeks. And this is in large contrast to mood and BPD that, as I mentioned, goes up and down intensely throughout the day. Also, bipolar disorder lacks the internalizing criteria of BPD, so lack of sense of self, the interpersonal storm, fear of abandonment, none of those features are present for bipolar disorder. I would say the similar is same for disruptive mood dysregulation disorder. There may be some overlap in diagnosis here, especially with the externalizing or acting out behaviors. That's why I think that some may give that disorder, DMDD, if some of the dysregulation and anger outbursts are present. That may be a better fit if it lacks the other internalizing criteria of BPD. And of course, there is some overlap with ADHD symptoms in terms of impulsivity, for example. However, BPD does not result in inattention or hyperactivity. So if those things are present, you may want to look at ADHD. And of course, ADHD can occur alongside BPD, and bipolar disorder can also occur alongside BPD. And so that needs a very specialized expert approach. And lastly, I want to talk about the effective treatment. Dialectical behavior therapy remains one of the gold standard evidence-based treatments for BPD. In fact, it was the first ever developed evidence-based practice for BPD. Focuses a lot on mindfulness, acceptance strategies, along with a lot of skill development. We're running a little low on time, so I'm just going to briefly touch on that there is a lot of evidence, a lot of research to support DBT's efficacy for treating BPD. Also, mentalization-based therapy is another evidence-based treatment for BPD. It helps them to effectively name, perceive, and interpret behaviors, thoughts, and feelings of self and others, which is often a big deficit in people with BPD. This can really be helpful for people with relational trauma. And lastly, and you're going to get access to these slides, so don't worry about jotting everything down right now. I want to give you some resources. So first, I would recommend this book, Borderline Personality Disorder in Adolescents. This is a great and easy read for parents of adolescents with BPD. We use this a lot and recommend to parents a lot at Evolve. I also highly recommend the National Education Alliance for BPD and their website, borderlinepersonalitydisorder.org. There is a lot of additional reading resources there, alongside a research database if you want to take a deeper dive into the research on BPD. And a sublink within that site is the Global Alliance on Prevention and Early Intervention for BPD. So that's an advocacy group that is fighting for much of what I'm talking to you about today, and is extremely valuable resource there. Okay. All right, let me see our time. So we have about 8 minutes left, and I see a lot happening in the chat and in the Q&A. So I want to take a look and maybe select some questions to address. Okay. All right, so I said, do you use dialectical behavior therapy? Absolutely. I'm trained in this therapy and support our programs with providing DBT at Evolve. How about people with trauma when they were able to be able to do it before? I'm not certain about this question, but as I mentioned, there is a lot of often a lot of trauma in the history of people with BPD. Not always, but oftentimes that is true, and it may play a role in the development of the disorder. How about a teen that used to be extra sensitive and now feels nothing and does not show much emotions anymore? Is this normal for BPD? I mean, I would say it could certainly be an experience of someone with BPD. I think that we see two phenomenon happening sometimes with people with BPD is that you can have unrelenting crisis where your emotions are coming at you in big waves all day, every day, and you're bouncing around from crisis to crisis all the time, and you're experiencing a lot of emotion discontrol. And then there's other people who have learned to lock things down instead, so to speak, where now they're in a state of emotion over control, where they're basically not allowing any emotion experiencing. And so they may say they feel nothing. They don't know how to access their emotions effectively at all. So I would say this is definitely possible for someone with BPD. Let's see. I'm seeing a lot of comments about probably the intersection between autism spectrum disorder and trauma and BPD. Of course, you can have ASD and BPD at the same time. And I think they may share some characteristics, particularly around emotion regulation and interpersonal function. And I think you need to have a skilled clinician be able to really thoroughly assess what can be attributed to what. Let's see. Okay. Someone is saying my daughter has 9 out of 9 criteria, but was not abused and was raised in an empathic and loving environment. Also, she did not really show any symptoms until she was 11. I mean, that's definitely possible. As I've mentioned, sometimes homes can be well-intentioned and have a loving environment, and the approach for that child may not be an effective fit for them. And I know that's very hard to hear as a parent, that your intuitive method of parenting may not have been what your child needed. And sometimes that's the case. So no one was bad, no one was abusive, none of those things. It simply wasn't a fit that yielded the kind of support they needed. And so the job now is to learn what the child does need and to be able to adjust the approach to help the child now. I see my son is coming out of residential and has a BPD diagnosis. How do I find experienced therapists that have worked with adolescent BPD? Yeah, again, I would strongly encourage you to find comprehensive DBT providers. So that means a DBT program or provider that would support individual DBT sessions, DBT skills training, and multifamily skills training alongside DBT skills coaching. I think the full model of that treatment is what research most supports in its efficacy for BPD. But if you are only able to find a therapist that provides individual DBT or just provides skills groups, you may be able to cobble together an outpatient team for your child. Let's see. Adolescents that have psychotic breakdowns where they see someone that no one else sees, plus they feel invincible, energized, needing to walk and move. Is this still BPD? Of course, based on this description alone, no. this sounds more to me like someone who might be having a manic or hypomanic episode if they're feeling like a discrete and clear period of time where they're experiencing this invincibility, high energy, needing to walk and talk all the time. That may look like mania or hypomania. And sometimes those symptoms can accompany psychotic symptoms like hearing and seeing things that other people don't hear and see. What type of successful medication interventions do you see with individuals with BPD? That's a complicated question. I will cautiously answer and acknowledge that I'm not a medical professional. So I can only answer like within my scope is what I've seen as an LMFT and working alongside various psychiatry teams over many years. Sometimes medications can help. I think it also depends on what other comorbid diagnoses there are. So if the teen also has major depressive disorder, yeah, then an antidepressant will probably be very helpful to them in managing that disorder. If they have comorbid ADHD, then perhaps medicating that would be effective. To my understanding, there aren't really any medications that are specifically approved, particularly for BPD, though sometimes some of our clients and that I've seen over the years may benefit to varying degrees from different kinds of mood stabilizers. Let's see, do you see it? Moving over to the chat, do you see BPD being on a continuum with varying numbers of symptoms and varying levels of severity? Of course. I think that that's the case for most of what's in our diagnostic and statistical manual is that even within meeting criteria for the disorder, there's varying levels of severity and impairment on functioning. And of course, like somebody who's in the middle of their recovery journey for BPD may still meet criteria and not be as severely impaired as they were, say, 5 years ago. And some people towards the end of their journey with later on in their journey may not meet criteria at all for BPD anymore. Like I mentioned, this can look very different for every person, and every person's journey is different depending on when they access treatment, what kind of treatment they access, and how and frankly how ready they are for that big change. And probably time for one more question. Can other therapy besides DBT help, like cognitive behavioral therapy, for example? We don't have access to BPD, or I assume DBT for teens where I live. CBT can be helpful in a lot of important ways. And I'll caution you that there are aspects of that treatment that are really change focused, and that for some people with BPD, this can feel quite aversive for them without the balance of the acceptance approaches that are incorporated into DBT. So what the creator of DBT, Marsha Linehan, saw in the beginning is that the patients she had who she was using CBT with would drop out of treatment a lot, and that they weren't feeling the validation and support they needed to be able to be motivated for change. That said, there is a lot of support that CBT can provide, and if it's the only help available, I would give it a try to see if it can be what your loved one needs. Okay. All right, well, thank you so much, everyone, for attending. I hope this was useful and that you got your questions and curiosities answered. We will be posting the slides in the recording of this on our site. We'll also kindly ask if you enjoyed the presentation and you'd like to leave us a review about it, feel free. There'll be a link for you to access to give feedback if you would like. Again, thank you so much for your attendance. Bye all.